Okay, and as people continue to join us, I'm just going to go ahead and get us started. We have a very exciting and very full presentation for you today. So I do want to just get going. Welcome everyone to our Colorado APCD Research Showcase. My name is Sarah. I work on the communications team here at the Center for Improving Value in Healthcare. I'm just going to kick us off and then turn you over to our fantastic presenters today. So just to start and give you a quick overview of what we're going to do in the next hour together. I will give you a very brief, very quick overview of CIVHC and the Colorado All-Payer Claims Database. Then we will turn it over to Caroline, Betsy, and Hannah to present their research that they've been doing using co-APCD data. Finally, Martha, who's a research liaison for us here at CIVHC, is going to take you through an exciting new resource that we have called the Data Dictionary. And then finally, we'll close out and go through any questions that you might have. Just to run through a quick bit of a housekeeping here as well. All slides, you are all muted at this time. But if you have questions that come up during our presenters' presentations, please go ahead and type them into the chat box. And our presenters will be watching the chat box and they will be responding to you in the chat box as your questions come up. We will go through questions at the end if we have time. Again, we are running a little short on time today. We are very full, but we'll try and get to some questions in person as well. But please type those into the chat box, and our presenters will try and get to you if you are not able to get to your question answered. There will be information for our presenters. The contact information will be shared with you after the presentation, so you're welcome to reach out to them. They're happy to respond to you via email with any questions that you might have. And this presentation is being recorded and it will be posted on our events resources page if you would like to revisit it at any time. So with that, I'm just going to take us through who we are, Center for Improving Value in Healthcare and the co-APCD. Next slide, Spencer. So CIVHC is a nonprofit. We are the administrators of the Colorado All-Payer Claims Database, and what's in the database I'll go through in just a second. Our mission is to equip partners and communities in Colorado and across the nation with the resources, services, and unbiased data needed to improve health and healthcare. And our vision is that everyone should have the opportunity to have equitable, affordable healthcare. Again, like I said, we are a 501c3 nonprofit. We are independent and operate objectively in a service-oriented nonprofit. Next slide, please. We work with partners across Colorado and across the state and across the nation, rather. We call the folks that we work with change agents. Those are individuals, businesses, and communities and community organizations who are working to lower healthcare costs, improve care, and make Colorado healthier. That pretty much runs the gamut of the healthcare landscape in terms of who we work with. That's everybody from clinicians, hospitals, employers, nonprofits, consumers, legislators, and of course researchers, which is who you're going to be hearing from today. Next slide, please. So we offer co-APC data in two different ways. First, we do a series of public reports that you can find on our website that identify opportunities to improve care. These are a number of interactive reports that cover a spectrum of topics, everything from telehealth service utilization to healthcare equity, prescription drug prices, far and beyond. So please check those out on our website. We also offer releases of non-public releases of co-APCD data that we license to folks like our researchers to conduct their own analyses and answer their own questions about healthcare and how healthcare is operating. Next slide. And this is what is actually in the co-APCDs very quickly. In the years that we have been operating since 2012, we have collected more than 1.3 billion claims. That covers 33 commercial payers as well as Medicaid and Medicare. There is trend information from all the way from 2013 through present day. 2025. That represents 70% of covered lives in Colorado, so the majority of covered lives here in Colorado, and that is over 5.7 million Colorado lives. What we don't have in the COAPCD, just a couple of little caveats. We do not have federal programs, so TRICARE, for example, VA at this time, or Indian Health Services. We also do not have the majority of ERISA self-insured employers. We do have some, but they submit on a voluntary basis, so it is unfortunately not all. And then, of course, we do not have uninsured or self-paid claims. Next slide. And with that, I'm going to stop talking at you and get to the real meat of why we're here and turn it over to our presenters. If we could go ahead and turn it over to, I think we say Hannah's taking it away. Oh, Betsy, sorry. Betsy, if you could go ahead.
Hi, everybody. I'm Betsy Cliff. I am an assistant professor at the University of Chicago in the Department of Public Health Sciences. And I am really interested in affordability of healthcare and out-of-pocket costs. And so I'm going to talk to you about two different projects that I've been working on with the Colorado APCD, focusing on out-of-pocket costs. Next slide. I'm funded for this work from the National Center for Advancing Translational Sciences, an R03 grant. And I just want to say too, I should have put on this slide, thank you to Civic, because they've been a really great partner. I really enjoy working with this data, and the organization too has been really helpful. So thank you to Civic for supporting this work as well. Next slide. Just a tiny bit about me. I teach health economics at the University of Chicago, consider myself a health economist. My main focus in my research is both health insurance design and cost sharing, or out-of-pocket costs. My background's a little bit different. Before coming to academia, I was a journalist for about 10 years. All over the place, most recently in Oregon. And I grew up in Eastern Washington and North Idaho. So I'm very jealous for those of you who are on this call who actually live in Colorado that you have big mountains near you. In Chicago, we do not. All right, next slide. Okay, so getting on to the research, like I said, I'm going to talk to you about two different projects. So the first one is on collaborative care. And if you want to know more, there is a publication in Medical Care. The second one is a project we're actually working on right now, trying to get published. So that's still pre-publication. It's on the cost of care for childbirth. Next slide. So beginning with collaborative care, you may or may not know that collaborative care is essentially embedding mental health care in a primary care setting. It's sort of a new model of care to try to more effectively and efficiently deliver mental health care to people who might need it. The uptake has been really low, despite that this model has been around for at least, I think, close to a decade. And there's no sort of, it's not really known exactly why uptake has been so low. People think maybe out-of-pocket costs are a barrier, but there hadn't previous to our study been any information on what the typical out-of-pocket costs were, so people didn't really know. So in the Colorado APCD, we looked for this. Collaborative care only became a CPT code in 2018, so we looked in 2018 and 2019 for anybody with a collaborative care code, and across all types of insurance, or actually, sorry, this says all types of insurance. We actually excluded Medicaid because there's no cost sharing for Medicaid in Colorado. And so next slide, please. So we looked at the out-of-pocket costs, the number of months you were in collaborative care. Collaborative care is billed by the month, not by the visit. So this is essentially an encounter measure. And then the percentage of patients with any out-of-pocket costs, and we compared these across insurance types. So what you can see here is that two things I want you to notice about this table. First of all, the vast majority of the people in our sample, despite that we looked across all insurance types, you can see that N for Medicare is much bigger than for commercial health insurance. The majority of people who are getting collaborative care were on either Medicare fee-for-service or a Medicare Advantage plan. Second, you can see that almost everybody with Medicare fee-for-service had some cost sharing. That was the least likely population to have no cost sharing, which makes sense because the fee-for-service benefit is more standardized. Most people with Medicare Advantage did not have any cost sharing, and commercial was about 50-50. When people did have cost sharing, the cost sharing was the highest in a commercial plan. Next slide. So what did we take away from this? The cost for collaborative care for patients is actually generally low. It's not likely to be the case that that out-of-pocket costs are a barrier in this case. We were surprised at the preponderance of people in Medicare plans. And I worked with a primary care physician at the University of Chicago on this, and her take was that likely what's happening is the networks are narrower potentially for people in Medicare. So this is people in commercial insurance might be referred out to a mental health specialist, whereas people with Medicare may not have that option. So Colorado is a state that's promoted the use of collaborative care, and take-up is pretty low here. So it does show that I think there's still some work to do on implementation of collaborative care models if we want to continue to promote their use. Okay, next slide. So now I'm going to move on to the second project. This is the one that's underway right now, and it is on the out-of-pocket costs for childbirth. Which is a major cost for young families. There's a lot that's known. There's a little bit of work on what the out-of-pocket costs for childbirth are, but it's not really known which families have the highest costs of care or what the impact of those costs are. So we had two research questions in this project. The first was that how does the cost of childbirth vary across income for people with commercial health insurance? And then the second one was about an impact. We wanted to know if high out-of-pocket costs were more likely to be associated with moves among families after they incurred this high cost. So the data we used are from 2016. We have 2016 to 2019 claims. So the births we used were from 2016 to 2018. And then for our second question, we limited our sample to births in which we could follow the patients for up to a year. And we had a few other restrictions that I will go into in a couple slides. All right, next slide. So for that first question, here's the table that shows our main results. If you focus on that second line that's bolded, the allowed amount, that is the actual negotiated price. The charge amount is was sort of the sticker price from the hospital. The allowed amount is the negotiated amount between the insurer and the provider. So what you can see there is if you look down those columns, you have quintiles of income. So just taking the entire distribution of people who are commercially insured and splitting it into 5 equal pieces, where quintile 1 is the bottom 20% of those who are of that income distribution. Quintile 5 would be the top 20%, and the ones in between would be those 20 percentile intervals. Sorry. So you can see that the allowed amount is basically the same no matter what your income is. But if you look in that third line where it says total out-of-pocket cost, total OOP cost, the mean is higher for people in that lowest income quintile. So for people at the lowest 20% of the income distribution, they're paying about $3,000 for each birth on average, whereas people in the highest income quintile are paying about $2,800. Then you can see on the bottom, like just another way to measure this, looking at the percentage of people who pay above $3,000 for a childbirth, you can see the percentage is higher for people who are at the bottom of the income distribution compared with people who are at the top of the income distribution. So this is actually, let's see. So this actually, well, let's see, I'll wait to do my conclusions. Why don't you go to the next slide? Okay, and then for our second question, what we are looking at again is whether or not people were more likely to move after they incurred one of these high costs for childbirth. and what if they did move, if they were more likely to move to a more or less disadvantaged neighborhood. So here we looked at a subset of births, as I said before, where you could trace people for up to a year after the birth. We also looked at births for which an out-of-pocket, like a higher out-of-pocket cost is not likely to be planned. For example, we excluded elective C-sections because people might be able to anticipate that that would have a higher cost than a vaginal birth. And then we also excluded types of birth where certain circumstances of the birth might be more likely to cause moves, like if you had multiple babies at once, or if you had a long NICU stay that's going to require you to get ongoing care. So what did we find here? We found that the probability of moving at all does not change for people with higher out-of-pocket costs. However, people with higher out-of-pocket costs are more likely to move to a disadvantaged neighborhood than people who don't have high out-of-pocket costs. We define disadvantaged neighborhoods by looking at census block groups, which are linked to individuals in the Colorado All-Payer Claims database, and then used the Area Deprivation Index to measure the amount of disadvantage in a neighborhood. So to give you a sense of the magnitude, if your out-of-pocket cost goes from, say, $1,000 to $2,000, that raises your probability of a move to a more disadvantaged neighborhood by 0.3 percentage points. About 3% of the sample is moving to a more disadvantaged neighborhood within a year after the birth, so that's about a 10% relative change. The effect is larger for families who live in a census block group that has a median income below $80,000. So next slide, please. So what are the takeaways from this childbirth cost project? I think the first one is that we haven't known before which individuals in commercial insurance are likely to be paying higher costs for childbirth. And it is in fact people who live in who are more likely to have lower incomes are more likely to also pay higher costs for childbirth. It's likely the result of insurance plans that we can't assign causality. We don't know exactly why, but what we think is happening here is that basically people with lower incomes are likely to have less generous insurance plans that protect them from out-of-pocket costs. Secondly, we found that people who have higher out-of-pocket costs are more likely to move to more disadvantaged neighborhoods in the year after childbirth. This is right now an associational study. We don't have a causal framework around this, so it's just one is associated with the other. Second, the effect is small. Most people are not moving at all in the year after childbirth, so it's just small magnitudes. However, I am pretty excited about this finding because, well, not for the fact that it shows some harm, but because this is one of the first pieces of evidence that I know of that connects out-of-pocket costs for common events with particular harms, and in this case, potential harms in terms of neighborhood quality and housing. All right, next slide. I think that's it for me. Thank you so much. I will, as Sarah said, I'll try to monitor the chat in case people have questions, and hopefully there'll be time for some questions after as well. Thanks so much.
Thanks so much, Betsy. That was really interesting. And we'll go ahead and turn it over to Hannah. If you have any questions for Betsy, please go ahead and just start typing them in the chat, and we'll try to make sure we have some time at the end here, and she'll answer away. But with that, go ahead, Hannah.
Thank you. Thanks for having me. I am disappointed in myself for not including an about me slide, but my name is Hannah Peterson. My pronouns are she and her. I am a chronic disease epidemiologist at the Colorado Department of Public Health and Environment. Two fun facts, which I'm convinced are not fun, but they are unique to me. So I'm also a Pacific Northwest girly. I grew up in Western Washington, so it's wonderful to have another Washingtonian share the space with. And I like to say that I have grandma hobbies. So I love to garden, I love to read, I love to eat, I love to travel. And my favorite thing is when all of my hobbies can converge. So like eating while traveling or reading while traveling, like that is the dream. But anyway, we can hop into it. So next slide, Spencer. So for today's presentation, I'll start with a quick overview of Colorado ADRD data to give us a scope of our work. I'll share a little bit about the Colorado State Plan and its implementation. I do want to pause for a hot second and talk through some of the acronyms that I'll use throughout and have already used. So ADRD stands for Alzheimer's disease and related dementias. We use this term dementia as an umbrella term for loss of memory or other thinking abilities that are severe enough to interfere with daily life. Under this umbrella term, when we use the word dementia, we're specifically referring to persons with a diagnosis of Alzheimer's disease, vascular dementia, Lewy body dementia, and frontal temporal dementia, as well as their care partners. So next slide. I'll start with a little bit of background, essentially where are we and how do we get to where we need to be? So next slide. So Colorado, if you don't know, is experiencing a growth spurt. So from 2010 to 2019, Colorado had the sixth highest rate of population growth in the nation. And it had the third highest rate of population growth among older adults. So in 2024, there were an estimated 922,000 Coloradans over the age of 65. And the Colorado state demographers project that by 2050, 1 in 5 Coloradans will be over the age of 65. As we know, age is the #1 risk factor for dementia. Alzheimer's disease is the most common form of dementia, and it disproportionately impacts communities of color, our rural communities, and their care partners. Alzheimer's disease is the 7th leading cause of death in Colorado in 2021. And in 2020, Colorado Medicaid spent around $635 million caring for Coloradans with dementia, and those costs are expected to increase by about 25% over the next 5 years. So with this rapidly growing, aging, and diversifying population, it became imperative for Colorado to maintain a strong focus on the health and wellness of adults, both in that 35 to 64-year-old age group, as well as the 65 plus age group, paying particular attention to those populations that are growing the fastest. The next slide. So one way the state maintains a strong focus on the health and wellness of adults is through the implementation of our state plan. So this is work that is funded by BOLD out of the CDC. BOLD stands for Building Our Largest, Dementia Infrastructure. This is a 5-year grant from the CDC, and it supports the implementation of the Colorado ADRD state plan. The plan consists of activities that, if implemented, will aid Colorado in succeeding in having a strong public health approach to ADRD, with a focus on risk reduction, early detection, disease prevention, and management, as well as avoiding unnecessary hospitalizations, and providing education and support to both Coloradans living with ADRD and their care providers. Next slide, Spencer. The way that this work is structured is through 4 different work groups. The E work group, which is to empower and engage and educate. The P work group is to develop policies and mobilize partnerships. W stands for assuring a competent workforce. And then the M work group is to monitor and evaluate our progress. And the work that I'll talk about today came out of that M work group. Next slide. And just to reiterate before I move on, the goals of the state plan are to use these work groups to build the competent workforce, ensure equitable access to healthcare and care planning services, and then develop policies and mobilize partnerships. Next slide. So I'll move into our current data landscape, essentially what we know and what we have, and kind of talk through a little bit about what's missing. Go ahead. So there are several data sources that tell us various pieces about older adults and their health experiences. We use Colorado Hospital Association data. This tells us about outcomes and admissions and mortality, but it doesn't really tell us about those who are living with dementia unless they seek medical care. Another source that we use is the Behavioral Risk Factor and Surveillance System. This is a population-wide survey in all 50 states and all major US territories. It comes out of the CDC. And ADRD has about 20 ADRD specific questions that appear intermittently on the BRFSS. This helps us understand experiences of caregivers, of those who are experiencing cognitive decline, and its impact on their health behaviors and other health outcomes. While it's generalizable to the population, it is a survey of non-institutionalized adults. So we are likely missing a large proportion of individuals with cognitive decline or cognitive impairment who are living in nursing homes or other facilities. We also internally joke about how it feels silly to ask people to remember if they are having memory issues, but these are validated questions, so we feel comfortable using them moving forward. And finally, we have a lot of program data. So at the community level or individual level, we'll partner with a program, a clinic, or community organization, and collect data and information that way. It's helpful for understanding whether that program was useful, but it often has small sample sizes. Findings are not always generalizable to a larger community or group, and often these projects are short-lived based on funding and staff turnover and all the joys of working as a government employee. So next slide. So even though we have robust data sources, there are still gaps in our knowledge. For example, some questions that we have that we don't have answers to are, how many people are living in Colorado with each type of dementia? Or which county do patients live in and which counties are they seeking care in? Do these counties even have resources to support ADRD patients and their providers? Another question we have is regarding cognitive assessments. They're often the avenue that patients use to receive the care that they need. And we're not sure of how many patients are receiving those assessments or whether or not providers know about them and how to administer them. And this is where, next slide, Spencer, the Colorado APCD comes in. So you can move us to the next slide. So in 2024, we submitted a sizable data request to the Colorado APCD. We got about 250 gigabytes of data, which severely compromised the memory of my computer, but we made it. And hours of support calls with Martha Myers on the call today and Rachel Jarjim, we were able to answer a few of these questions. The first is, what are the counts of ADRD in the state of Colorado? How many members are living with each type of dementia, and where are members living? So we'll dive into each one of these briefly. So when looking at the counts of ADRD by year, we see that on average between 2017 and 2022, there are about 44,000 patients in the Colorado APCD who have had a diagnosis of dementia. 2017 is sort of an anomaly, but we expect that some of the number of distinct members diagnosed during this year is higher because it includes members who were diagnosed prior to 2017, but had a healthcare encounter of interest during 2017. Next slide. So when looking at the number of distinct measures by diagnosis type, we see that there's about 54,000 members with a diagnosis of Alzheimer's disease between 2017 and 2022. About 67,000 members have a diagnosis of mild cognitive impairment, which is often seen and used as a precursor to a dementia diagnosis. The largest group here is the other ADRD bucket. And we're currently working with some physicians at the Colorado University at Anschutz to refine our diagnosis code bucket to see if there are groups that fell into this other category that should be placed somewhere else. So next slide. And finally, our final question is, where are patients with ADRD living? So we mapped out the county of residence for our members with an ADRD diagnosis. And what we see is that counties with the highest rates are congregated in Southeast Colorado, Northeast Colorado, and primarily rural and rural resort communities. These values and statistics align with the Colorado Demographer's Office, where we know that rural communities have higher proportions of older adults when compared to urban counties. Next slide. So when we add the CO APC data to our arsenal, it helps give this work context. We're able to quantify where individuals are living, which helps direct our work and identify local partners. We're able to quantify where the number of members and the number of members this work could potentially impact. And for the first time, we're able to have granularity by analyzing the data by each of these diagnosis categories. And this allows us to put our money where our mouth is, and acknowledging that not all dementias are created equally and not all patients and care providers need the same things. So we're able to tailor our interventions and our outreach to each of these subgroups. Next slide. So what's next? We are really hoping to dive into cognitive assessments. So trying to get at whether or not members are receiving cognitive assessments, reviewing physician utilization of advanced care planning and cognitive assessment codes. And we hope to flesh out experiences of those with living with ADRD. So expand the above analysis to available demographics and other healthcare related claims. And then our final strategy will be creating data products that enable our partners to have access to this data as they also implement the state plan. So thank you so much for taking the time. My email is on the next slide, and I'll answer questions in the chat.
That's great. Thank you so much, Hannah. So yeah, go ahead and type any questions into the chat. And again, hopefully we'll be able to do a little more open Q&A here at the end that Hannah will answer as we go through. And finally, to take us home, we have Caroline. Go ahead.
All right, thank you. Hi, everyone. Yeah, my name is Caroline Sloan, and I am calling in from Duke University in North Carolina. So unfortunately, no close by large ski mountains. I was corrected earlier. There are some small hills that I could maybe take my 3-year-old child to, but I wouldn't do it myself. So I'm going to talk to you about real-time benefit tools and their impact on prescription fill rates in Colorado. So you can go to the next slide. These are the disclosures of me and my team. Next slide. So just to give a little context, 1 in 3 adults have so much difficulty accessing their medications that they skip pills, cut them in half to make them last longer, or abandon them altogether. Next, this is called cost-related non-adherence. And cost-related non-adherence has been shown to lead to reduced quality of life, increased functional decline, increased rates of hospitalization, and increased mortality. One solution to making medication prices more transparent so that patients and their clinicians can discuss the financial trade-offs of different treatment options and maybe select one that makes both clinical and financial sense is to develop something called real-time benefit tools. So I'm going to talk to you a little bit about like the regulations behind them. So the federal government has been pushing to increase medication price transparency over the last 5 or so years. In 2019, there was a federal regulation that began requiring that Medicare Part D plans provide medication cost estimates to prescribers at the point of care via the electronic health record. And then in August 2025, so just a few months ago, another federal regulation began requiring that all electronic health records include a medication cost estimator tool directly in the interface of the EHR. Next slide. So the cost estimator is called a real-time benefit tool, or RTBT, and I'm going to show you how it looks in the EHR to give you an idea. And hopefully, Spencer, you can keep track of where I am, but I will yell at you if you don't. So the first thing that the clinician does, so this is how it looks like when I'm in my primary care clinic with my patient. So I'll type in a medication order into a little box like that. And then once I type it in and, type enter, then a new little box shows up. And that's basically a checkout cart. I can then review the medication order, and then I can sign that order. At University of Colorado Health, where I conducted the study, if there's a lower cost alternative that could save $2 or more for the patient, the real-time benefit tool cost estimate window pops up as shown there. And that window shows the cost of the initial prescription, as well as the cost of up to 4 lower cost alternatives that could be a different medication altogether, like in the same therapeutic class, or a different pharmacy, or a different day's supply. If clinicians don't want to wait for the pop-up, they can then click on that little estimate button that's circled just a little bit above. Once the window pops up, the clinician can then respond in several ways. Next click. Thanks. So the clinician can either ignore the window and just close out of it, or they can consider the information, maybe talk about it with the patient, but still keep the order after having had a discussion about cost with the patient. Or they can consider the information and submit a new order by clicking on the alternative that's offered here, or closing out of the window and typing in a whole new medication. So there's a lot of kind of leeway to do whatever you want with this information. Next. A major goal of the real-time benefit tool policies is to lower patients' out-of-pocket costs and improve their ability to pick up their medications at the pharmacy. That's like all over the regulations that have been written. But the evidence on that so far is mixed, in part because prior studies haven't had the right data to adequately answer the question. So there have been really 3 main studies on this question so far. The first one, next, used Medicare Advantage claims data to compare patients who were receiving care at institutions that did versus didn't have a real-time benefit tool. And they found that adherence and costs were similar across institutions. But because they only had access to claims data and not EHR data, they had no information on what was actually going on in the EHR, like how often did the RTBT actually pop up. So then the second study used EHR data and found that when the RTBT popped up, patient costs tended to go down. But all this group could assess was the cost estimated by the RTBT, not the amount patients actually paid at the pharmacy, because they didn't have claims data. So we don't know if patients actually saved money or not. And then there was a third study that used EHR data and data from their in-house pharmacy and found that adherence was better after the RTBT popped up, but it was a really small study that didn't look at fills outside of that one in-house pharmacy. Next slide. So in our study, we wanted to overcome the limitations of these prior studies to get a final answer on whether the RTBT actually improves adherence and reduces costs using a combination of claims and EHR data. So our research questions were, next, you can just put all of them. Do RTBT cost estimates impact whether patients with chronic conditions fill their prescriptions? Number 2, do RTBT cost estimate displays impact the amount that patients actually pay for their medications at the pharmacy? And then finally, do results vary by patient insurance status, race, ethnicity, and chronic disease? Next. So we conducted a retrospective observational cohort study of patients receiving care at University of Colorado Health, which is a large academic health system that serves about 3.5 million individuals in Colorado and the surrounding states. Sorry, Spencer, you can next a bunch of times. And patients were observed from June 2017 to December 2022. And the reason we picked that observation period was that the University of Colorado Health introduced their RTBT in July 2019. And so this gave us a pre-RTBT and a post-RTBT period. Next. And again, next. Oh, sorry, wait, go back. Too many animations, clearly. So I also want to note just one last thing, that the UC Health RTBT is able to provide cost estimates for many, but not all insurance plans. Some insurance plans just don't provide the RTBT with access to any out-of-pocket cost data. So the RTBT could just never pop up for those patients. And I'd be happy to talk through the technical details of that if anyone has questions. All right, next slide. So we included all adults aged 18 plus. Next. And next, you can just put all of them up. Yeah, so we included all patients who were age 18 plus, who had Medicare or private insurance. The RTBT doesn't really work for people who have Medicaid, so we didn't include them. Patients had to be taking at least one medication, and we included people with at least one of the following chronic conditions. So type 2 diabetes, AFib, heart failure, rheumatoid arthritis, or COPD and asthma. And we picked those conditions because they tend to have at least some medications that are on patent and therefore expensive. Next slide. We used two main sources of data. UC Health's EHR data included patient demographics, medication orders, and RTBT data. And the RTBT data included things like, did the cost estimate display, how many lower cost alternatives were there, what were the types of lower cost alternatives that were shown, things like that. And then claims data included census block group, insurance type, diagnoses, medication fills, and medication out-of-pocket costs. And we were able to link those two large data sets, and doing so allowed us to overcome some of the limitations of the prior studies. So we were able to include a larger number of medication orders, so not just those that were sent to in-house pharmacies. We were able to account for whether the RTBT window actually displayed, and we were able to see how much patients actually paid for their medications, not just what the RTBT estimated. Next slide. So in our analysis, we were interested in two main types of exposure. So next. First, we created a pre-post RTBT indicator with the pre-RTBT period being June 2017 to June 2019, and the post-RTBT period was July 2019 to September 2022. And then within the post-RTBT period, so that darker blue part of the arrow, we looked at what type of exposure to RTBT patients had. So next, if you show that figure, Spencer, some patients have no RTBT access. These were patients who were enrolled in insurance plans that just didn't provide any access to any out-of-pocket cost data, like I alluded to earlier. And then next, other patients did have access to RTBT. They were enrolled in insurance plans that could provide access to medication out-of-pocket cost data if needed. And then next, within that group of patients who had access to RTBT through their insurance, there was a group of people who we labeled as RTBT display. And these were patients who actually had an RTBT cost estimate window pop up at some point during a visit in the post-RTBT period. And it could have popped up automatically because of a $2 or greater savings potential, or maybe the clinician clicked on the estimate button. We didn't really make the distinction between those two scenarios in this study. All right, next. So we then evaluated three outcomes. First, we looked at first fill rates. So that was defined as the average proportion of new prescriptions that were picked up at the pharmacy per patient quarter. And new prescriptions were defined as medications that hadn't been previously prescribed to the patient in the previous 6 months. Then we looked at refill rates, which was defined as the average proportion of refills that were picked up at the pharmacy per patient quarter. And then finally, the mean out-of-pocket cost per 30-day prescription. And we hypothesized that patients with RTBT access and RTBT display had greater adherence, so first fill and refill, and lower out-of-pocket costs compared to patients who didn't have access to RTBT. Next. And next, yeah. We used difference in differences methods for our analysis, and our regression included indicators for the pre versus post period, the RTBT exposure group, and the interaction between RTBT period and RTBT exposure group. And then we included demographic and clinical characteristics. So at baseline, we found that about 30% of patients had no RTBT access in the post-RTBT period, and about 70% did have RTBT access. And among those with RTBT access, a little over half had the cost estimate window display at some point during a clinic visit during those few years. Next, patient demographics were pretty similar across all RTBT exposure groups. So mean age was 66 to 67 years, 41 to 46% had female sex, about 80% were non-Hispanic white, and about half were enrolled in traditional Medicare, with fewer enrolled in Medicare Advantage and commercial insurance plans. Next. And then clinical characteristics were also similar across groups. 60 to 61% were taking 6 or more chronic medications. Over half had either diabetes or COPD and asthma, and then a smaller proportion had AFib, heart failure, and rheumatoid arthritis. Next. And just a reminder that a lot of those conditions coexist, which is why none of those numbers added to just 100. So now let's get into the main results. So next slide. In the pre-RTBT period, the average rate of first fill, so meaning that proportion of new prescriptions that were picked up at the pharmacy, was 64%. And in the post-RTBT period, after adjustment for confounders, we found that patients with RTBT access had first fill rates that were 5 percentage points higher compared to patients with no RTBT access. And we also found that patients in the RTBT display group, so meaning those who had actually had the window pop up, also had a 5 percentage point increase in rates of first fills compared to patients who had no RTBT access. Next slide. So then looking at refills, in the pre-RTBT period, the average refill rate was about 55%, and that's lower than the rate of first fills, which is consistent with other studies finding that patient adherence often drops off after that initial prescription is filled. And in the post-RTBT period, after we adjusted for confounders, we found that, again, RTBT access was associated with an increase in medication refill rates in both the RTBT access and the RTBT display groups by about 2.5 percentage points. Next slide. And then finally, when we looked at out-of-pocket costs, the average out-of-pocket cost spending on a 30-day prescription was about $25 for a prescription where the RTBT was providing a cost estimate. And in the post-RTBT period, we didn't see any significant difference in out-of-pocket spending in the RTBT access group or the RTBT display group compared to the no RTBT access group. Meaning that RTBT access and display didn't really seem to have any impact on what patients paid out of pocket for their prescriptions as a whole. Next slide. And then when we conducted our planned subgroup analyses, we had a few interesting findings that I'll show you. Next, yeah. Among patients who were enrolled in traditional Medicare, we found that RTBT access and RTBT display were associated with a 3.6% increase in first fills, similar to the main analysis, but there was no effect on refills and still no effect on costs. And then when we looked at people enrolled in Medicare Advantage, we actually found a decline in refills after display or just having access to RTBT. And then when we looked at people who were enrolled in commercial insurance, we found a much greater effect on medication fills, both first fills and refills compared to the main analysis. Still no impact on cost. And then when we looked at the subgroups or when we kind of stratified by chronic condition and stratified by race and ethnicity, we really didn't see any difference compared to the main analysis. But some of those groups were so small that it's kind of hard to tell. And I think, larger group study would need to be done. All right, next slide. So limitations of this study include that it's a single institution study, and RTBT display was defined as an RTBT cost estimate having ever been displayed for a patient across the entire observation period. So even if it just occurred like one time in July 2019, and never again after that, we still counted them as an RTBT display person. And then medication fill data aren't perfectly accurate. A lot of patients, in my experience, fill their prescriptions without using their insurance if they're too expensive, through things like direct-to-consumer pharmacies like Mark Cuban's Cost Plus Drug, and other venues like that. All right, next slide. So in conclusion, this is the first study to evaluate the impact of RTBTs using EHR and claims data merged together, thanks to our access to the Colorado APCD. We found that while RTBT doesn't lead to meaningful cost savings, it does appear to be having its desired effect on adherence. And we hope to conduct additional research using UC Health and Civic data to understand how to increase that RTBT effect on adherence. Right now, there's evidence that clinicians really only look at those RTBT windows like 15% of the time. So how can we increase that? We also want to understand how it is that RTBT improves adherence without reducing costs. Is it that knowledge of costs ahead of time and the ability to have cost conversations with clinicians are helping patients, even if their costs aren't going down? And then finally, we really need to better understand why RTBT effects differ by insurance type. I don't have any great answers right now, but would love to hear any thoughts you have. And I think that's it. Yeah, all right, thanks.
Awesome. Thank you so much, Caroline. We are going to finally turn it over to Martha, who is going to show us the very cool new data dictionary that we have here at Civic, and then we'll have a couple of minutes for questions, it looks like. So go ahead, Martha. Oop, Martha, you're on mute.
So sorry. Thank you, Sarah, and thank you to all our presenters today. It's fun to see how the data can be used and the very different avenues that can be approached in the data. So we have expanded our data dictionary to now include more more information than we had previously. So this can help you if you're pre-data element selection and even after you get the data to better understand the data that you did receive. For instance, you can see the data type, so whether it's a variable or a number, this length, the maximum length, the requirements, whether or not it is required, and then how it aligns with the data selection guide, so the DSG, so you can see the definition that a submitter has versus what you have. And this is all in one package. And if you'll advance the slide, just to walk you through where you can find this, it is on our website. It is under the data user resources and under the application document. So now everything is there in one spot. So you can align your data element selection form with the data dictionary to make your decision post and then to look at your data after it's received. The other thing that I want to remind you all of are our data offerings. Yep, perfect, thanks. Is the de-identified data sets. That is the predefined set of data elements that is available. It's an off-the-shelf kind of item that gives you an ability to slice and dice and bring bits of data together into what you need to maybe do your pre-work. The great thing about the de-identified data set is it still is at the line level. It's not just summary data, so you have the details that you need. And we also do sequencing, so you know, even though you don't know the exact date of data of a visit, you do know the sequence of that. Also, we still have available the custom reports. You can take advantage of the fantastic Civic analyst to do the heavy lifting of understanding and analyzing your data and get a report in like a summary or a Excel or Tableau format. And finally, all of our favorites, which everybody in this group used today, was a data set or an extract. You identify the data elements you want, and then we put together a data set for you. And there's some extra steps, of course, but it allows you the full access to 485 data elements. So that is all. Thank you, everybody, for being here, and I'll hand it back to you, Sarah.
Thank you so much, Martha. Yeah, this is a really new, exciting resource that we're thrilled to have to make working through our big DESF a little bit easier for everybody. So with that said, looks like we have just over 5 minutes now left. So if there are any questions that you have thought of for any of our presenters today, please go ahead and type them in the chat box, and we can do a little Q&A now. And then we'll go ahead and close it out. So I'll give everybody just a minute or so to type in some questions that you might have. And just give it a couple of seconds here in case anybody trickles in. And as we wait for that, you can reach the emails for all of our presenters are in the chat. and you can see them here on this page. You will also get an email from us in the next couple of days that will be a follow-up to this presentation with a link back in case you'd like to watch anything back, share it with anybody you know, whatever you may like to do. And then if any questions do come up, wake you up in the middle of the night wondering, how did they do that? Go ahead and reach out to any of our presenters at these email addresses. And with that, not seeing any questions, so we are coming up right on time here. So that'll work out. We will go ahead and close the presentation for today. Thank you all again so much for joining us. And if you have any additional questions that come up, or if this sparked any ideas for your own research projects, you can reach out to us at coapcd@civic.org, and we'd be happy to talk you through any more of those products, any questions you might have about the data, or anything else. So thank you all so much. Have a wonderful rest of your day, and happy holiday season. Thank you.